Good morning, everyone. This is Charlene Gamis, and as a clinical education specialist at InBody, I would like to welcome you all to today's webinar in our InBody Present series. Today, Ross Sherman and Dr. Brian Hatzel will be speaking to us today about their research using segmental multi-frequency BIA to detect and monitor soft tissue injury. Dr. Ross Sherman is an associate professor at Grand Valley State University, where he has been teaching in the exercise science degree program since 2008. His current research focuses on three main areas: soft tissue injury assessment, post-exercise recovery strategies, and athlete load and recovery monitoring. Dr. Brian Hatzel is a full professor and past chairman of the Movement Science Department at Grand Valley State University. His research has spanned examining muscle firing characteristics of the glenohumeral joint, responses to fatigue, injury prevention, and identification. At the end of the talk, attendees will have a chance to ask them both questions by adding them to the Q&A section. So without further ado, I'd like to welcome our guest speakers, Dr. Sherman and Dr. Hatzel, to join us.
Thanks, Charlene. I appreciate the opportunity to talk, and to everyone else at InBody and all attending the webinar today. I know Dr. Hatzel and I are really excited to present some information and some data to you. So just wanted to say thank you to everyone at InBody, also all the people attending the webinar today. Hopefully over the next 20-30 minutes, Dr. Hatzel and I can outline some really interesting information, and we're excited to give you some insights into the work we've been doing over, I guess now the last couple of years with obviously the break for COVID. Just to quickly introduce my area, as Charlene mentioned, my background is exercise physiology, and you know, in terms of what I bring to the project is just the understanding of recovery techniques, athlete monitoring, and just that how we use technology in both the exercise physiology and sports science workplace.
So I echo Dr. Sherman's thanks for the opportunity to be able to share some of our work. I historically have functioned as an athletic trainer. I'm an athletic trainer educator, but also have functioned in the clinical setting. And so Dr. Sherman and I both have collaborated on this project to merge his physiologic and sports science interests with my understanding and interests in benefiting the function of the clinician and utilizing what we hope has a promise to help inform our function as clinicians while working with our patients, both in the sporting environment as well as in the occupational environment. Thanks for this opportunity.
Okay, so as Charlene outlined, our topic of the conversation today is going to be looking at segmental multi-frequency BIA to assess and manage soft tissue injury. And just a really brief overview of BIA, and hopefully something that a number of you are familiar with. And it's, when we talk about BIA, we're talking about the non-invasive measurement of both resistance and reactance within a number of different spaces and tissue in the human body. So intra and extracellular resistance, and also membrane reactance. And a vast amount of literature has identified the relationship or the link between both resistance and reactance to fluid content as well as membrane integrity. And then as a mathematical calculation from those two metrics, we get the phase angle, which is being used as an indication of both whole body and cell health and function. More primarily of interest to Dr. Hatzel and I was this developing concept that we can use BIA to start to assess changes in both fluid distribution and membrane structure, but also that it could be a diagnostic tool to help with those areas of composition and structure within the tissue of the human body. Just to refer back to those points, you can see especially in the bottom left picture down there, this concept that the intra and extracellular fluid compartments, and also then the membrane integrity measurement points of the BIA device or BIA technology. In terms of its uses, a number of these that I'm sure a good number of us are familiar with, and primarily the assessment of body composition is BIA's history, both in the athlete, the healthy individual, and also in disease states. as had previously been outlined in webinars in the series that have been presented before us, and I've given some examples there. Obviously, we know with cancer and kidney disease are two disease states that measurement of body composition, specifically phase angle, have been really useful in examining a little bit more detail. We also know that BIA is used for nutritional considerations, both in terms of assessing basal metabolic rate and maybe hydration status of the individual. But primarily of interest for Dr. Hatzel and I is this idea and the developing idea that BIA can be used with injury. And that's a very broad term, but for us, it's this focus on trauma and trauma that may have been occurring in both an occupational or in a sporting environment. And I know something that Dr. Hatzel has some information on later. And especially this idea that the BIA is starting to be used both by clinicians and by researchers to assess changes in the tissue following both a trauma and a sports injury. And that's not to negate occupational settings either. And there's something that we use in our field of the idea of the tactical athlete. So we have a sporting athlete and a tactical athlete, and the tactical athlete is someone who works in maybe the military or firefighter, law enforcement type environment.
Dr. Sherman, if I could just stop you for a second. It appears that your slides have frozen a bit. I know that we had in a rehearsal.
Is that changing or not?
No.
Yeah.
I'll go ahead and take over the screen share, Dr. Sherman. 1 second.
Sounds good.
Thank you, everyone, for your patience.
Great, thank you. So apologies, technology is wonderful when it works and maybe not so when it doesn't. But as I was saying, the primary focus and interest for Brian and I in our work is this small area of injury and use of BIA with injury, and the concept and the I guess the application of it, and that we're starting to use it now both in clinical settings and in research settings to assess changes in tissue following both trauma and sports injuries. And so this kind of leads us to our next kind of information, I guess, and I'll let Brian talk to you about these next pieces.
Right. So as Ross indicated, right, our interest is primarily in looking at soft tissue injury. And so the purpose of our project and our investigations here are to look at the musculoskeletal or soft tissue injuries. So the muscle strain, the ligament sprain, tendinopathies, and or rupture. And we know that result from either micro or macro traumatic injury episodes, overuse, and we're also identifying fatigue-related muscular dysfunctions that we know that exist within our athletes and those physically active in the occupational setting. You know, if you look at the impacts of soft tissue injury and what's the so what of that, or what's the issue with soft tissue injury. If you look at a sporting example, you have these athletes where organizations have invested significant money in large player contracts, but we also see shortening seasons, or essentially the need to be able to keep the athletes participating at a very high level in those condensed seasons and post seasons and whatnot. Just some data here in the U.S. pro leagues. On average, a team will lose between $3 and $13 million, and 3 to 8 games potentially for an athlete per season, right? And so that's a significant monetary as well as time loss occurrence when you look at perhaps maybe a 12 to 15 or 16 game season. Now, if you look at the English Premier League, specifically soccer or football, as Ross usually likes to refer to it as, right? Each team stands to lose upwards of $63 million to injuries totally each season. So when you start to look at that those numbers can be pretty significant. And for my colleagues on the ground in these clinical settings, keeping athletes participating, it's definitely an answer that they have to provide to their administration and their general managers, if you will, on a regular basis. But beyond the sporting environment, I think what's also worthy of discussion, perhaps even a larger discussion here as we move forward in the future, is the occupational athlete, if you will. Those that are active in the military setting or law enforcement setting, or those industries that have laborers or need to be active in some type of physical activity to produce their work on an 8 or 10 or 12-hour shift. So working in a factory or maybe even landscaping or things like that, right? So you look at those time loss. And so OSHA tells us that about 35% of the time loss injuries that we see in a year are related to soft tissue injury. And financial impact for that, according to the National Safety Council, is about each sprain or strain accounts for about $32,000 loss, either to the individual that sustained the injury, to both the individual that sustained the injury as well as to the organization. An interesting component here with the soft tissue injury is it's not necessarily just the significant trauma that occurs that you see on the field and an athlete go down or somebody slips and falls and gets hurt, but some of the non-contact, a large proportion of the injuries that account for these time loss injuries are the non-contact occurrences. So for instance, like a hamstring strain or maybe a tweaked ankle or maybe a shoulder, a shoulder problem that's inhibiting somebody from participation. So our current approach in injury assessment at this point, as a clinician, where are we? How does it look? What do we do to evaluate and assess an injury at this point and establish a return to participation plan? So our current approach is pretty subjective. Absolutely, to my colleagues here in this webinar, there are objective measures that we can add into, and many of us do, into our assessments for patient-rated outcome measures and other clinical assessments. But largely, it's based off of the subjective information of what the athlete is telling you. Right? How do they feel? Does this hurt? Does that hurt? And that transcends through the rehabilitation or the return to participation process. It's very common for somebody to be referred for an MRI, either from the orthopedic surgeon or a clinician, to identify what's happening. But we have to be reminded that an MRI largely is providing information relative to the structural integrity of the tissue. So not necessarily a good evaluation of the quality of that tissue at that time. So some of the concerns that we have is the lack of the physiologic measures of the responses to injury. So we all know from a pathophysiologic standpoint, there is responses that happen from acute, chronic, subacute type injuries, and identifying where we are in that pathophysiologic cascade of events following injury or illness it will help the clinician in better identifying their plan for return to participation. That's also not to say that the MRIs are very expensive, and this is very much a privileged perspective here. Those that can afford, so yes, our professional athletes, many of our college athletes are going to be able to get an MRI and identify what's happening structurally, but many will not be able to. Those just add to those costs that we mentioned from the National Safety Council and OSHA. So how do we determine an appropriate therapeutic intervention? And so currently, right, we're going based off of what my best practice has been, what my interpretation of the situation is, taking into the subjective information from the athlete or the patient, and what I know to be a typical injury response based on where they're at in their timeline. So based on that lack of that objective determination of the stage of the tissue repair and the readiness is really what has gotten Ross and I pursuing this investigation specific to the sporting and occupational environments.
Thanks, Brian. And I think as we develop this interest in using BIA with soft tissue injury, we're able to reflect on some of the previous work that's been done in this area. And it's been a recent development. We're looking in the last 10 years that the majority of the work has been done that relates to soft tissue injury and trauma. And there's been an interesting sort of story develop in that using a localized BIA analyzer. So this is looking at the specific limb and then placement of electrodes, both proximal and distal to the injury site. People have found and started to identify that you can use BIA with trauma injury. So there was a study by Bioelectrical and colleagues that looked at the trauma unit and identified that BIA was able to detect the side of the torso which the injury was on, and primarily associate that with the change in the phase angle response. Sanchez and colleagues also used a non-invasive BIA methodology, and were able to show that changes both in the resistance and the reactance in skeletal muscle was evident after an injury to that muscle. So starting to develop this kind of confidence that localized BIA can be useful and helpful with assessing changes in tissue in response to injury. More recently, Nescalorde and her group in Spain have done a large number of studies that form the backbone of our kind of foundationary work for Brian and I. And this is, their work really started to identify BIA use with athletes in the professional environment. And they put together a really nice package of work has really started to help us understand that a localized BIA can help both identify the severity of muscle injury, but also provide some assistance with return to play decision. And that's not necessarily making the decision, but that the timelines match, so that when the clinician makes a decision of return to play for the athlete, that the markers that come out of the BIA analyzer seem to identify that the tissue is also at a state that is back to a baseline or pre-injury level. Most recently, their group last year actually published a really nice study that used the same BIA localized analyzer, and they started to show that even if you start to identify a little bit more detail in the injury, so looking at myotendinous and myofascial injury discrimination, that BIA starts to provide some increased resolution there, and that specifically, again, the reactance or the muscle integrity marker can discriminate between severity of injury and the myotendinous tissue. So this is something that's really helped us drive the area forward. So that was localized BIA analyzers. If we think about, and obviously as prepare for the segmental multi-frequency BIA, we know from previous research that this technology is extremely useful and accurate in estimating a number of different body composition markers across total body water, extracellular water, lean mass, fat mass, primary markers of body composition. However, more recently, people have started to suggest that phase angle could be useful for looking at evaluation in the athlete across both the overall condition, but also body segment changes with training responses. And it's obviously something that matches nicely with Brian and I's work. But just want to reiterate, before we get into our work, that prior to now, no previous research has actually used segmental multi-frequency BIA with soft tissue injury. So reflecting back to Nescalorde's work, all their research was using localized 50 kilohertz BIA analyzers within the actual injured limb. However, on the flip side is we know that numerous professional and collegiate teams have access to segmental multi-frequency BIA technology. So as we kind of develop into that, we know there's a practical usage that's out there, and then a research kind of focus that's in a slightly different but allied area. So this generates the question that, that's been pushing Brian and I forward, and that's that, can segmental multi-frequency BIA be used to both detect and monitor responses of soft tissue injuries, and specifically in collegiate athletes?
So the purpose of our investigation, we were able to enroll 180 current NCAA Division II collegiate athletes. Those sports spanned, as listed there, football, baseball, men and women's basketball, softball, women's soccer, women's lacrosse. Each of those that were enrolled in the study were healthy and cleared for full participation for team activities, and they were cleared by their athletic trainer prior to their season. For the purpose of our conversation today and for our study, we defined injury as an injury occurring when a change in participation status occurred over at least 7 consecutive days. So there are often times when an athlete may have something minor but doesn't really change their participation status. We chose not to include those in our investigation for this purpose. The measures were performed at the start of the season. So a baseline non-injury scan. We took another scan on the InBody 770 at the time of injury within 24 hours. That proved to be pretty successful, although there were a time or two when athletes were away at competition when injuries occurred that posed, that we have in our data set as well. But for time of injury within 24 hours, the best that we possibly could. And then every 7 days during either the rehabilitation or the return to participation protocol. And then just prior to return to participation, which was deemed as such by the athletic training and physician staff, we took another scan there. So the actual procedure in utilizing the InBody 770, we did at each time when they came into the athletic training facility prior to any treatment and prior to any type of rehabilitation, the athlete was asked to stand for at least 5 minutes prior to the InBody. So we didn't want them just rolling out of bed for a morning workout and stepping right away onto the InBody. And then, of course, we had them clothed in shorts and a t-shirt with no jewelry or electronic devices, which we know can cause some issues in the measures for us. And the comparison then within the InBody 770 and each of these scans was the involved versus the non-involved limb for those that were injured. So as far as our data set goes for our presentation today, we had a total of 6 soft tissue injuries that were reported and then the subsequent monitoring through our study, as well as in collaboration with the athletic training and medical staffs. We had 4 acute injuries within the appendicular region. We had a torn anterior cruciate ligament, or ACL, that also had a concomitant MCL, or medial collateral ligament, which resulted in surgical reconstruction that we'll present today. We had another torn ACL. We refer to it as maybe a clean ACL, if you will, based on the data that we were provided from the athletic training staff, meaning there was no other concomitant contributors to the injury. They did undergo surgical reconstruction. We had our third injury is a sprained anterior talofibular ligament, or ATF ligament, also known as oftentimes as a lateral ankle sprain, that went through a non-surgical approach to rehabilitation or return to play. And then we had another sprained anterior talofibular ligament that resulted in rehabilitation. Had 1 subacute injury within appendicular region, one of which that Ross and I have had many discussions about, as you will see as he presents the data on this, that was defined as athletic training and medical staff as a tendinopathy in the medial distal flexors. But one that was interesting in that the diagnosis was nondescript. And this athlete in particular had a lot of swelling that was transient based on activity rather than a particular tendon injury. So it was more of a global upper extremity injury here. That resulted in rehabilitation and maintenance through the course of the season, and in this case, postseason. And then our last injury here is an acute injury within the appendicular region, but we didn't have a baseline scan on this, but still thought that the case was compelling to share with you, and that it was a dislocated shoulder that resulted in a torn labrum, subsequent surgical repair. And so we look forward to sharing this data with you.
Okay, so to just help explain what we did. So coming off the 770, we get the full or the main report as you can see on the slide on the left-hand side. And you know, there's a wealth of data on here, and of interest to us, and I always think this is kind of slightly amusing to me. Right in the bottom right-hand corner, there's this tiny little table that's tucked away that really gives us these metrics of BIA, or I think of them as the raw BIA data. So both the reactance, the phase angle, and impedance. And it's measured, as you can see in the zoomed in image, across those multi-frequencies that the 770 provides us. And for us, in terms of the tissue characteristics, we know that the most appropriate frequency within human tissue is 50 kilohertz. So as we look across that 50 kilohertz line, for Brian and I, when we're looking at the data, we know we have an injured limb and then what we're calling the non-injured or non-involved limb. So the comparisons we run are between those two values. So if we look in this case example here, a non-injured right leg compared to an injured left leg would give us a 28.5 kilohertz comparison to a 21.8. So would result in about a negative 23% difference. And so that as you look at the subsequent data that I'm going to present to you in the following charts, it should start to give you a feel of what these numbers mean. So you'll see on the vertical axis always a limb to limb difference. So negative being a compromised change. So as it starts to drop, we see increasing amounts of either inflammation or damage. And then time along the horizontal axis in some measure of either weeks or months in 7-day increments. So the first athlete we wanted to present was a sprained, as Brian was saying, lateral ankle ligament. The athlete got a non-injury baseline scan, as you can see at day 0, presented to us 2 days after the acute injury. And once again, as Brian mentioned, most of these delays when it's not within 24 hours is because athletes are on the road and just access to the 770 obviously is somewhat time constrained. But what we can see is initially profound inflammation within the limb. So within that lower limb, nearly a 10% difference against the non-injured limb. And then over time, leading up to the time when the boot was off or was removed or was able to be removed by the athlete, a small, steady decrease in inflammation. So the purple dashed line returning closer to baseline, but at the same time, the reactants or the muscle membrane damage actually worsening over time from baseline down to about 7% difference at its worst. Some points of interest for us as we watched the data coming in and look back over time, we could identify that at day 20, as I said, the athlete was able to take their foot and out of the boot. At that time, the next scan we took, which also in consideration was a week later, we saw an interesting dip back in negative response in both the reactants and the resistance from that limb. So indicating that the tissue was responding to the having to be weight bearing and having more mobility across the tissue. The athlete was also at day 25 post-injury was actually reintroduced to gameplay only. So they engaged in gameplay at the weekend, and then for the rest of the week were working with the athletic training staff with treatments and non-practice environments. And I think what the data showed us was that the athletic training staff were able to sustain their treatments as well as allowing the athlete to play at the weekend. It didn't exacerbate the issue, but what you do see is by day 45, we hadn't seen the athlete return back to baseline values. We didn't get a return to play decision because the season ended, with the athletes still going through this cycle of non-practice yet gameplay at the weekend. So I think initially Brian and I start to look at this as it starts to help us identify the changes that happen, that the 770 is starting to pick up both longitudinal and acute responses to differing environments that the athlete may be in. So we'll move on to the dislocated shoulder and torn labrum, and so a little bit more of a complex injury and response, and there's phases to this. So the first phase that I've identified to you here is what I've called the pre-surgical phase. So the athlete came to us, unfortunately, 14 days after the injury. What you can see here from the purple line being the resistance, little to no inflammation difference between the involved side and the non-involved. However, a fairly sustained reactance difference. So there was obviously some damage occurred within the limb that was sustained across day 14 through 63, which was the pre-surgical phase. It didn't seem to get really over time much worse, but it didn't either get better in this individual. We then see, obviously, as we'd expect, a pretty dramatic drop in both those two markers post-surgery. So the surgery was on day 74. We saw the athlete on day 78. And the reactants, just to kind of give you an idea, a drop from 5% to almost 30% difference. So, 25% change in a negative environment, which makes sense when you've had a surgical intervention. The athlete then went home for the summer, so was in their off-season phase, and then reported back to the institution and then also the athletic training staff and our study. And on day 220 post-injury, was able to, based on the surgical assessment, able to participate and get involved in shoulder mobility work. And what we see, and this is something that was really positive for Brian and I, was although the reactants showed an initial dip, that the 770 was able to pick up these, what we may think of as small, subtle changes occurring with more of a training stimulus, more of a mobility movement rather than a purely injury response. And what will look really nice at the end of this timeline and tracking of the athlete was by day 260, they'd had a return to play decision made. And at that point, the both reactants and resistance showed a return back to, we don't have baseline obviously, but had gone back to little to no difference between the previously involved and non-involved side. So really nice longitudinal story there. This is the example that Brian mentioned earlier, which was identified as tendinopathy in the forearm flexors. Once again, a couple of phases of response that are interesting to kind of talk through. The athlete came to us as a baseline scan at the start of their season. So we have the baseline scans at time 0. And if we look at that, you can see that there's obviously something underlying in this individual. So we see, inflammation at 12% difference between involved and non-involved side as we identified them later. But they went into their season as normal. We didn't see them for the first half of their regular NCAA season, and then the athlete came to us after being referred by the team AT because of just ongoing and worsening conditions. So when we saw them on day 54, their inflammation had changed from 12% to nearly 20% between lateral and contralateral side, and even their damage marker was down at nearly 12% difference again. And we see this timeline of fairly sustained or maintained both resistance and reactance differences. But then the points of interest for Brian and I, as we look at this and try to explain what's happening in these peaks and troughs, we see a large drop in both the markers in response to tournament weekends. So the team made the playoffs, and so they go away for weekends where they play high volume of games, and obviously for a pitcher, a high volume of work. And the dips are in response to the tournament weekend. So you'll see a gap in the preceding point before the area that I've highlighted. And that's when they're away for their weekend of the tournament. And then the data that's at the low points is the data that when they return to campus. So we see this almost response to the training load of the tournament weekend shown in really severe inflammation and muscle damage. And that's repeated again at the second tournament they went to as part of their playoff season and playoff run, where the team was really successful. So we got to see this long playoff exposure. One thing of really interest to us was once the team had finished and went into the off season, the athletes stayed on campus. We were able to get some off season markers from them. And we start to see towards the end of the off season or towards the start of the summer break that the athlete had started to return close to their baseline values, but not fully back to baseline. So even after 99 days of this tracking, we still hadn't seen them return, but at least some partial positive change. The athlete was then scanned, luckily was around campus after the end of the summer, so nearly 4 or 5 months later. And what we saw at that time, after being away from the game for a period of time, was that the reactance or the damage in the limb compared to the non-involved was almost back to a 0 point. So 0% difference between the two sides, but there was still some inflammation issues. Of secondary interest, or maybe primary interest, how you look at it, the athlete, unbeknownst to us, was actually dealing with a leg issue, as we called it the hidden leg issue, because we were treating, or we were scanning them for their arm. But when we looked at the data, and this is maybe the beauty of the segmental multi-frequency data from the 770, we identified actually that there was some fairly obvious or fairly marked differences in the reactants in the leg data that ranged anywhere from 6 up to almost 13% difference. So we would equate to maybe a moderate type of issue in that tissue area. And when we spoke to the athlete, they actually disclosed that they'd had some lingering hip complaint in their, what we've called their opposite leg, but in essence for a pitcher, she was a right arm pitcher. And so the left leg is the leg that takes a lot of the load when it comes to the actual pitching mechanics. So something of interest to us, and as we move forward, is this identifying maybe other things that may be happening to the athlete. And then the final data set we have, and this is probably our probably our showcase data set, was working with the torn ACL MCL surgical repair athlete, and this is a male football player. Just as before, we have this pre-surgical phase where the athlete came to us, got a baseline scan in the healthy, non-injured state, and we can see there some fairly close values between involved and non-involved side. Then came to us 4 days post-injury. And we can see some pretty dramatic changes in both the reactance and the resistance, but also a really nice clean pre-surgical phase where inflammation was removed away from the site, and some of the damage was also minimized and reduced as well. Had surgery on day 27, and then we saw them almost 10 days later, day 37, when they came to us, and we can see once again, as just with the surgical repair in the shoulder and the labrum, a profound decrease in both markers as a result of the surgical intervention. But over the course of the next 140 days, so 3 to 4 months, we track the athlete every day, or every week, sorry, some really nice positive longitudinal change. So the thing to look for is obviously the progressively decreasing difference, so getting closer back to the baseline, or the 0% difference as well, if you think about both of those two different environments. A few things to note of interest for Brian and I, especially, and for everyone listening. We see these little troughs in the curve, in the reactance curve especially, but also reflected in the resistance and inflammation. At day 40, the athlete was introduced to blood flow restriction training as part of their program, working with the athletic training and physical therapy team. And as a subsequent effect of that, we see this acute or transient decrease again in the reactance that's reflected or is repeated when the athlete engages in full weight bearing at day 52. And we actually saw for a couple of weeks after that a decrease in reactance, so increasing damage within the tissue. And then again at day 72, the athlete was had added into their program squatting to 90, and we see just a much smaller decrease, but still a little dip there in the reactance line. But as we look further along the timeline, we don't really see any other further decreases. Of note to us was at day 142 was the deadlift past 90 was introduced, and then at day 149 was introduced the single plane running into the rehab program. So I think what we can see there is that as we get later in their timeline, that introducing these extra stresses had little to no impact on the measurements that we took in terms of reactance and resistance. Unfortunately, we never got the athlete back to return to play, which was a real disappointment for Brian and I, because of, in essence, literally COVID shut down everything. So we had this really nice timeline and track of this athlete, who also was the team AT acknowledged was probably one of their model athletes in terms of going through the rehab, was engaging in all their rehab appropriately. As Brian mentioned earlier, the team AT said this was like a kind of a gold standard example of how an athlete should go through their rehab. So it gave us good confidence that the data we were seeing was appropriate to some of the inferences we may make. And then just to wrap up some of the data, and this is something that we reflected on after we looked at the data, and in kind of response to Nescalore's work that started to look at the differentiation between severity of injury. The first thing we looked at was a resistance marker. So could resistance help us identify or differentiate severity of injury? And obviously we only have two severities, both so moderate and severe, but we also have the surgical response as well. And I think as you look down that vertical column on the right-hand side there in the purple box, it's pretty clear that there's no real difference across severity of injury or surgical response in the resistance. So that may give us some initial suggestion that resistance is maybe less useful in determining or helping us understand the severity of injury in the limb. In comparison, and obviously we have to be very careful in terms of how much data we have for this, but when we look at the reactance, and this was the measure that Nescalore's work suggested was the most appropriate for delineating or differentiating severity, what we see in a number of cases, not all cases, that the severe injury or the severe response to a severe injury seem to suggest reactance values in the mid to high teens, and that whereas the moderate may be in the 0s to 10% change range. And then when we look at the surgical intervention, we see that, you know, of the 2 or the 3 surgical interventions that we have data for, values in the mid to high 20s in terms of difference. So the torn ACL that we didn't show data for is the lower number in both those 2 examples. And that may be something that's due to the nature of both the injury. As Brian said, it was what would be regarded as a clean ACL injury and then repair, but also maybe just the physical characteristics of the athlete as well. So just creating less damage and less impact in that area. So in terms of concluding, and obviously now it's, you know, trying to wrap this thing up, I think initially Brian and I, you know, part of our work was about gaining confidence using the 770 with athletes. You know, there's a bunch of work with localized BIA analyzers, but the 770 is a different animal, and how does it work, and what do we get from it? And I think, you know, we have to be mindful of, we're getting raw BIA data from the 770, and it's good data, and that it's similar to, but we can't directly compare it to other devices that use different methodologies. So the localized BIA data, we can't use their stratifications or their thresholds for the different severities, because the multi-frequency BIA is measuring slightly different areas. So we think about a whole limb with a segmental multi-frequency versus a localized and targeted area with a local BIA analyzer. But I think in terms of what it really means, it suggests to us that the early data that we can use segmental multi-frequency BIA to both detect and monitor soft tissue injury. But as we move forward with this work, yeah, we obviously need more soft tissue injury data, especially for the muscular tissue. We also would really like to examine in a little bit more detail the intra and extracellular water data that comes out of the 770. So there's a second report, the water report, that would be of real interest to us to help understand more the response to the injury. But also as well is establishing these normal variations. So what is an injury and what is a normal healthy change or variance across a population, both for the limb, for a sport, and also for a gender. And once we establish these norms, it then starts to give us a little bit more confidence to identify when a value may be of clinical interest to us. So to wrap this all up, you know, I think looking at Nesca Lorde's work and our early information from our pilot study, as you may think of it, I think we can gain some confidence that reactance seems to be more directly related to severity of soft tissue injury, especially in the human athlete model. And also that the InBody 770 could be a really useful and potential diagnostic tool for clinical professionals working with athletes. And so I think that, you know, that's a really nice summary of our work, and we just kind of see where we go from here. So I think now's a great time to thank again InBody and everybody for tuning in. And if people have questions, and we can get into those and try and help you understand where we are.
Thank you so much, Dr. Sherman and Dr. Hatzel, for sharing your research with us. As you mentioned, Dr. Sherman, we would like at this time to open up to questions from the audience. And as a reminder to all of our attendees, if you did have any questions for either of our researchers this morning, feel free to cue them into our chat box at the bottom of the screen. And it looks like we do have some questions already coming in for you both. So in terms of looking at your results using reactance to determine injury severity, is it possible that it is not just severity, but maybe the location and number of areas affected by the injury, which you think affect changes in reactance values? And have you thought of ways of making the classification more specific?
Yeah, I mean, where we are right now, and I think this, you know, it's a really interesting question. That's something that Brian and I have talked about a number of times. And as we start to develop more data, I think we get more confidence in understanding where these potential thresholds may be, especially for the severity of injury and what the 770 multi-frequency data gives us. But I think initially we're starting to at least appreciate that the machine and the data is able to respond or reflect small changes or sensitive changes in the tissue. And so I think the that's where I think we initially start from, is this point of it's picking up changes, and now we just need to develop more data to understand what those changes specifically may be, and how to understand the magnitude of change as well. Because it's one thing to, that we see change, but it's what does a 10% change mean, both functionally and clinically. And so I think there's something there that we need to explore in a little bit more detail. In terms of the location of injury, I think there's definitely something that we need to explore and understand a little bit better, both in terms of the segment, but also in terms of the vascularization around that injury site. And that's going to have a fairly impactful response to the data that we collect.
Right. And thank you for sharing that. Now, outside of resistance and reactance values, have you possibly considered looking at the impact of ECW to TBW ratios, or even more so, more deeper than that, looking at the segmental water values, so ECW ratio, ICW, ECW, and the impact of those measures in the return to play protocol, or even as a marker for signs of overtraining and injury prevention rather than just rehab post-injury?
Yeah, I think, once again, I think we're definitely interested in looking at those values. We need to probably spend a little bit more time to exactly understand what those numbers are giving us, and the responses that we see to the in the data set we have. I know we've looked at, very anecdotally, we looked at the torn ACL, MCL injury, and looked at some of the water, especially the intra and extracellular values in the segments. And there's clearly some changes occurring. I think some of it comes also back to the sensitivity or the ability of both either resistance or reactance to detect change. It seems that, obviously, as we've probably shown in some of our pilot work, that resistance seems to return faster, as we may expect from a normal physiological mechanism, whereas the reactance seems to be, or the damage seems to last longer in the tissue. So I think initially maybe some of the water values may be of interest. I think long-term, with a long-term injury and rehabilitation, those water values may, it's hard to say right now, but there may be less physiological impact on those data points, because I think they're going to return back to a 0 point faster than our reactance values.
Mm-hmm. Now, and further to the values that you were looking at, being that the previous research only looked at the one area, and we know with InBody, we have this direct segmental measurement, and especially the trunk value that we have you found that the trunk values correlate with injuries in that area as well? Or what have you kind of seen in your data from that?
Yeah, the trunk values are interesting, and I know Brian has some interest, especially with the shoulder injuries. One thing that we encountered early, obviously, and just as the model that we use for the data collection, also there's no contralateral trunk measurement. So we only have, the trunk is a single cylinder. It's not like a involved, non-involved limb. So we have this, what we may think of as, for the moment, a natural control comparison. So any change in the trunk data would have to be from a baseline value, and degree of change or percent change from baseline in the trunk. So I think there's something of interest in the trunk data. It would need us to investigate both normative data for the trunk, but also to, I think, get a cleaner understanding of exactly like where and what the trunk is identified as in the segment. But I think there's definitely some areas, and I know Brian, with the shoulder, and I know the hip as well, is an area where we may see crossover between both the limb or the appendicular region and then the torso.
Mm-hmm. I agree. And, I'm sure it will serve as great future data collection for you, or even possibly a future study for both you and Dr. Hatzel. We're getting a lot of, great comments, audience members thanking you both for your presentation. By chance, can you please quickly just re-explain how you were able to calculate the resistance and reactance values from the InBody data, and any thought on the monitoring of other health conditions such as lymphedema?
Yeah, the reactance and resistance values, obviously the reactance is directly given to us on the report. So that's a nice, easy value to get to, just on that, the table that was highlighted in the bottom right corner on the main report page. The resistance is a calculation just using some basic trig, and I am by no means a trigonometry wizard, as I can't even say the word. But we know that, with mathematical manipulation from knowing the resistance or knowing the reactance and the phase angle, we know we can work out what the resistance value is. So that's where we go from. And the reason why resistance and reactance, that obviously that's the norm in the research when it comes to BIA and injury response. So just to provide us with a consistency and continuity with those other data sets.
So specific to the lymphedema part of the question there, I think that if you look at our forearm case that we've presented, I shared a little bit of doubt on the diagnosis that was shared with us, and think that there was a level of lymphedema that was likely experienced there by that particular athlete. And that's showcased by those resistance values that we see that kind of ebbed and flowed depending on the intensity of the workout and their participation in those tournaments through the season. So definitely something that I feel pretty confident that you can look into and at least see some type of changes there in that limb.
Great, thank you both for sharing. And I think even on touching on the lymphedema aspect, we have seen other clinicians as well as other researchers use it within their practices on patients who do have lymphedema. So it would be interesting to see, as you mentioned, Dr. Hatzel, if you had an athlete who was experiencing some type of condition like that, what that would look like and how that would affect their injury for sure.
Sure.
Now, in case anybody did miss it, could you speak on which local BIA device was used in addition to the InBody 770?
Yeah, we didn't actually use a localized BIA device. That was all coming out of the Nesca Lourdes work back over in Spain. I can't remember the specific device name off the top of my head, but I know it's a commercially available device that they use. It's just an electrode based analyzer it's consistently used across all of their research in their professional athlete model. So just to clarify, we haven't actually done any localized BIA measurements yet, and then maybe something that Brian and I look at and are interested in, like comparing the multi-frequency 770 with a localized value, just to understand if we see a 20% in the 770 data in reactance difference, how does that compare to a localized BIA analyzer, just to try and quantify or adjust for those differences in the measurement technique.
Thank you for clarifying that. We have another question here. It says, are we saying, looking at the result sheet of InBody 770, we are able to diagnose soft tissue injuries? And if so, could you please give an example based on the result sheet? For example, how do we know it is an ACL injury?
Yeah, I think this is a great question. No, the intent of interpreting this data is not for the diagnosis of a particular condition. We're not able to tell that as far as a particular structure that is involved. However, putting it into using it as a tool within the toolbox for the clinician, I guess, as I oftentimes refer to my colleagues and students as, it allows us to help better assess what's going on. Is there something going on? So here, for the purpose of this study, we wanted to be able to say to ourselves, Ross and I wanted to say, can we tell if something is happening within the musculoskeletal structures? And I think that we're able to tell that something is happening, right? You combine that with an assessment of your orthopedic surgeon, your athletic training staff, or others. I think it gives you some more clinical confidence in how to address the situation with your athlete or with your patient. Oftentimes too, through the rehabilitation protocol over time, we wonder, are we pushing a little bit too much? Are we introducing a modality too early, or can we maybe push a little harder? I think that there may be a utility for this device in being able to help inform your clinicians in the future to help have a little bit more clinical confidence in establishing those plans and carrying those plans out. But by no means do we mean to intend or say that the InBody can be a diagnostic tool to any particular condition.
And just as a point of reference, obviously, as you look back over the slides, the example report sheet that I had on the slide, where we zoomed in on the reactance and resistance and phase angle box. That's actually the relates to the ACL MCL injury data. So that's actually the initial scan post-surgery. So you see that negative 23.5% reactance difference. So just to give you an idea, that's a really good example of real information and real data that Brian and I were looking at. So if you want to look back at the slide and understand and relate the report to the data and what that may look like, that gives you an idea of kind of how we use and see those numbers.
Thank you both for your thoughts on that one. Now, you did talk about the importance of returning athletes to play. How would you apply this information to treating injuries and speeding up the recovery process?
Right, that's an interesting piece. I think it helps to limit the guesswork that goes into return to participation. And there's so many things that dictate a return to participation. What type of activity is the patient engaging in, and how does that correlate with the injury or the limitations, either into the biomechanics or specifics of that particular motion that those folks need to do. But the way that I intend to explore further and how to potentially use these data is when I'm making a shift in an advancement in the rehabilitation protocol. So for instance, when I make a decision on removal of a boot and into from non-weight bearing to a weight bearing activity, I want to know what's responding there over those few days to see, am I getting a decrease, or am I getting a change in either of these values that may tell me that I'm okay to progress further into maybe walking uphill or maybe even jogging, or do I need to back them off and hold them at that stage a little longer as I get strength increases, and so on and so forth. So I think we can see those similarities and those parallels across the board to injuries. I think that it's detrimental too if you, for instance, were to take a soft tissue injury like a hamstring strain that account for significant time loss in NFL, right? That they've highlighted this, they've put this out there, that this is a real problem, right? They certainly are providing a lot of external funding to look into hamstring soft tissue injuries specifically. We don't want to release somebody with a hamstring injury too early. That would significantly increase their risk of a second hamstring injury or worsening of their current. And so it's probably not a second, it's probably a worsening of the initial that they had. So we don't want to do that. Now you're doubling, possibly even tripling their time loss. So when we make our decision, we want to have as much clinical confidence as we possibly can. And I do think that the InBody data helps us to be more confident in those decisions.
Thanks for sharing that, Brian. Now, Drs. Hatzel and Dr. Sherman, you have both collected great data so far. And as you continue your research and pivot in any future directions, do either of you have any closing remarks you'd like to share with us, or maybe what you foresee as next steps in your research?
Yeah, I mean, we're obviously, it's the tip of the iceberg. It feels like, in a way, something that Brian and I talk about a lot is this, as we get more injury data, we can really build our confidence level with what we're seeing. But I think from my perspective, from the physiological aspect, is introducing or starting to actually get some like measures of bloodborne markers, both of damage, but also then the repair and regeneration process that goes on in the body, and starting to try line up what's happening. And Brian mentioned this earlier, this idea that right now we don't have a good objective understanding of what's happening physiologically in the body during post-injury phase. And so, we can assess things qualitatively from the outside, but if we can start to get some markers of what the body's actually doing and what point it is within its repair regeneration of that tissue, it starts to then help us line up. And once again, it's always the timeline is starting to say, well, X number of days post-injury or X% increase from the immediate post-injury point, we start to get more confidence that this is now indicative of the end of the repair phase, and now the tissue is starting to rematrix and it's starting to create more vascularization around the new tissue. And so we can start to identify what that may mean for the athlete in terms of their ability to take stress in that tissue. And I think it's something that Brian talked about is obviously the reintroduction of too much stress too early can obviously have a negative impact on that new tissue that's been made in the injured area. So for me, that would be really interesting to get into some bloodborne markers to tie up with the 770 data that we're getting.
Thank you so much for sharing. So thank you again to both of you for taking the time to talk to us today. I know there are so many more questions we would all definitely like to ask you, but unfortunately we are at the end of our time. Again, we're so grateful for your research and for sharing the brilliant work that you are both doing in injury and athletic rehab. If you need to reach out to either Dr. Sherman or Dr. Hatzel, please use the emails shown on the slide here. Shermaro@gvsu.edu and hatzelb@gvsu.edu. To all of our attendees, we hope this was both informative and inspiring and that you'll consider joining us in future webinars. Please stay tuned for our upcoming webinars from researchers at City of Hope and MD Anderson. More detail on those to follow. We look forward to having you join us again. If you need to contact us, you can contact us by reaching us at clinical@inbody.com. On behalf of all of us on the team at InBody, I want to wish you all a great rest of your week. And as always, we encourage you to see what you're made of.